Gunasekara, consultant radiologist with special interest in interventional radiology at Apeksha Hospital, Maharagama. He will speak on the radiological aspects of pancreatic cancer.
Good evening. First of all, I would like to thank our Palliative Care College to organize this kind of oration and teaching session. And congratulations to our first orator, Professor Samadhi Rajapaksha. So my part is actually imaging part of the pancreatic carcinoma, and actually we have intervention and management part, but with the time I would like to focus on imaging part because it is the most important part to diagnose a pancreatic carcinoma, because as you all know it's a very notorious cancer. If you diagnose it early as possible, you will able to do something and treat the patient. So when we think about the modalities that we can use, first we here know the idea about what is pancreas and the anatomy. So all the things covered by Ranga. So it's easy to me, but without knowing the anatomy, we can't predict in CT or even at ultrasound. So we have to know about the location and structures which is related to the pancreas when you do imaging and reporting any kind of pancreatic pathology. So it's retroperitoneal structure which is related to a lot of vital other structures, and those details always need to plan a surgery or other treatment. So these are the anatomical things. So we have both exocrine and endocrine part. So these are the some cancers, actually pre-cancer stage tumors in the pancreas located in the tail, body, and at the unstable process. So some are actually benign. With the time, they may grow into cancers, and some are totally benign. There is age distribution of all these, which some were presented in young age and others in old age. So as Ranga said, most of these cancers located in the head and neck, and few in the body. So when we straight go for the radiological part, we can use all these modalities to image this pancreas. So when we think about X-ray, few tumors of the pancreas get calcified, so we can see those in X-rays. This is not actually a pancreatic carcinoma, but it's diffuse pancreatic calcification, maybe with calcific pancreatitis or other conditions. As in this X-ray, we can see some calcification in the body and the head area in some pancreatic tumors. So next one is the barium study, which we don't use nowadays, but we used it previously to detect and to assess the dysphagia. So in dysphagic patient, we do this barium move contrast meal and follow through. In those studies, we can see narrowing at the second part of duodenum, which is at the pancreatic head. So this second part of duodenum will give a bulge into the duodenum with a smooth margin or irregular margin. If it is smooth margin, it may be a benign pathology most of the time. But if it is irregular or ulcerated like appearance with shoulder mean sharp borders, that we have to think about pancreatic carcinoma. With the history and other findings, we can say there may be a pancreatic carcinoma which is invaded into the duodenal wall. That's why we get this irregular appearance and proximal obstruction. So next one is the most important and widely used one in Sri Lanka and Asian countries basically. So when we are managing and when we imagine the pancreatic pathology, so we have to think about ultrasound scan first because of the availability and low cost imaging modality that you can get an idea whether it is at least normal or abnormal. So when we do ultrasound, we need fasting and other preparation to see the pancreas properly, because as you all know, it is in retroperitoneal structure, partially covered by stomach and also the bowels. So we can't easily see the pancreas by ultrasound. So when we do ultrasound, the radiological part, most of the time we can't see pancreatic lesion at once as you think, because it is not easy to see a pancreatic tail lesion or distal body lesion by ultrasound. So most of the time we see lesions in the liver or around the pancreas. Those are actually metastasis which is come from pancreatic primary. So when we diagnose a hypoechoic, like black dots in the liver, then we have few primary lesions to look at. One is actually pancreas. So if we think it's a pancreatic metastasis, so we go here and there and turn the patient to various positions and look at the pancreatic head, neck, body and the tail, because the tail actually located close to the spleen, so we can see the tail through the spleen, then through the left lobe of liver. So these are the examples of pancreatic metastasis. So this is actually metastasis from pancreatic cancer. This is also same. So this is the usual appearance of pancreatic carcinoma, which actually a hypoechoic lesion located in the pancreas with irregular margins and invade here and there. So calcification is usually not there, but you can see with associated with pancreatic other pathologies. So the margins are always very ill defined because it invade here and there with the to the surrounding structures, maybe blood vessels or duodenum, and cystic areas are seen if it is mucinous type. So the next one is CCT. In CT, I have to highlight the preparations because we need good preparations. If we are planning to do a CT for pancreatic carcinoma patient, usually we give oral water to distend the structures like small bowels and duodenum around. It's a must because otherwise we can't see the extension and differentiate the invasion into the surrounding structures. So in CT, we may see a small poorly enhancing lesion in the pancreas with irregular margins with or without invasion into the surrounding structures. So there may be lymph nodes around the main lesion with or without liver metastasis. So this is another example. Even we can't see the primary pathology because of edema and tissue change because of the primary carcinoma. We can see multiple liver metastasis. So we always suspecting pancreatic carcinoma in this background. So the next one I should say with the radiological involvement we can use ultrasound and CT for biopsy of pancreatic carcinoma. If we can access by ultrasound, we can get the biopsy by going through the stomach even or out at the around the margin of the stomach or peritoneal part. Or if we can't access by ultrasound, we can use the CT to access for biopsy. Next one, if we are treating or managing the patient palliatively, if we need to do any biliary stenting, he can use ultrasound for that. Okay, next one is MRI, which is advanced than CT to image the local disease, not metastasis. It's actually for the local disease. So we have to think about the indication because surgeons requesting the tissue planes where they invade and whether they can go through it and take it out without harming. So by doing MRI, we can specifically say the local extension and invasion into the structure because the appearance and the tumor margin is well seen in ultrasound MRI than CT or ultrasound. So if we think it's invade or we want to exactly clarify the invasion margin, better do MRI for as further imaging to before the surgical procedure. Next one actually advanced PET CT, but it's available in Sri Lanka now. So in PET CT, we can assess the metastasis in any part of the body. So FDG avid lesions. It means that it take this radioactive glucose into the tumor or metastasis and give you bright spot like this. So these high activity areas may be primary lesion if it is in the pancreas, or it may be metastasis in other areas like liver or in the lung, even at the brain. So if we want to see the extension of the metastasis, we can do PET-CT and we can do it for follow-up even, because if you think it's early recurrence, it's better to do PET-CT than MRI or CT, because sometimes these post-surgical changes will mix up and we can't exactly say whether it's early recurrence or not. But even a small 1 centimeter area, which may be post-surgical fibrosis in CT, or a very small, maybe reactive type lymph node in CT, can differentiate by PET-CT, because this pancreatic carcinoma is very aggressive type cancer, so we can get a very bright spot even it is very small. So it's better to do follow-up or early recurrence assessment by PET-CT than other main 3 tools. If it's a routine follow-up, we can do by ultrasound just for screening, and then CT or a MRI. Those are the imaging part. Actually, I don't have slides for intervention arm because I focus mainly on the imaging part. What we can do when we manage the patient palliatively, as Ranga said, if biliary obstructions are there, we can put retrograde stenting by using ultrasound or CT. We can puncture the bile duct and put a stent and relieve the symptoms. Or if we want to reduce the tumor bulk, we can do ablation. We can reduce the liver tumor bulk if need, or we can ablate the local disease even. Those are the radiological involvement in pancreatic carcinoma management. Even though it's a small cancer, it's a very aggressive cancer, so we have to diagnose it as early as possible to plan proper treatment or even to do proper palliative management. So that's all for today, pancreatic carcinoma. And this is a frozen river. It looks very calm, but it's not exactly. Thank you.